Okay, so the research is all about craniopharyngioma removal through endoscopic assisted microscopic surgery. The paper is published in IOSR journal. These are the authors corresponding by me. So quickly move into the abstract. 1 to 3% of all cerebral tumors that are benign tumors called craniopharyngiomas, which come in two varieties: the childhood type, which affects children between the ages of 5 and 10, and the adult form, which affects patients between ages of 50 and 60. The initial symptoms include visual, endocrine, hypothalamic, neurological, and neurophysiological manifestations, and they progress over time. The preferred course of action is surgery. Adjuvant therapies include intratumoral injection of chemotherapy medicines, gamma knife, and post-operative radiotherapy. In this study, we evaluated the role of endoscopy in assisting microscopic surgical removal of craniopharyngioma. 11 patients underwent surgery from different races and different countries. Using the subfrontal technique and a microscope, all procedures were carried out. After the procedure, the endoscope was used to look for any remaining tumor in subchiasmatic and retrochiasmatic regions, as well as to see the posterior portion of the tumor that at the microscope couldn't see. This allowed the surgeon to determine whether the tumor was adherent to the hypothalamus and whether it should be removed. There were 11 instances in this study, 4 of which were craniopharyngiomas of the infancy variety and 7 of the adult kind. In 6 cases, total removal was accomplished, 5 cases of adulthood type. In 5 patients, an Ohlmeyer reservoir was placed, while 5 other cases required a ventriculoperitoneal shunt. Only 2 of the individuals experienced persistent diabetes insipidus. The rest all experienced post-operative transient diabetes insipidus. Pituitary hypofunction was observed in 3 individuals before the surgery, and 2 more cases experienced post-operative pituitary hypofunction, both of which required hormone replacement therapy. Because of its connections to the optic nerve hypothalamus and vascular system produced by Willis circle and its perforating branches, the craniopharyngioma is one of the most complex and problematic tumors for all neurosurgeons to treat. After the removal of craniopharyngioma under the microscope, endoscopy plays a part in decision making. So you can see in the figure here it is located. This is craniopharyngioma. This is MRI image of one of the patient. So moving to the introduction, there are 1.3 craniopharyngiomas for every million person years. For this, there are 2 age groups, childhood and adult type. So it is a benign tumor. And despite being situated in a crucial region connected to the hypothalamus and neurovascular structures, every effort must be made to achieve through resection. Subfrontal, intrahemispheric, peritoneal, transcallosal, transventricular, and transphaneal approaches, as well as the various modifications such as extended transcellular, transdiaphragmatic approach, and transsphenoid, transtuberculum cellae approach have all been used for the resection of craniopharyngiomas. However, compared to transcranial procedures, the rate of cerebrospinal fluid leakage is much higher in transsphenoid than transcranial surgeries. The lateral growth of tumor or the encircling of circulatory structures are 2 factors that limit the transsphenoid approach. Total excision of this tumor is challenging due to its intermediate ties to optic nerves, chiasm, and hypothalamus. The level of hypothalamic pituitary complex, the optic nerves, and chiasm are typically where the anatomic challenges in anti-resection are encountered, where the resection may become limited. So the microsurgery enhances the removal of majority of tumor. That has been claimed that in up to 75% of instances, entire resection is possible. The total resection rate has increased by almost 10% as a result of the addition of endoscopy to the microsurgical toolkit. So for the treatment of craniopharyngiomas, a variety of techniques have been utilized, including surgery alone, surgery combined with the insertion of OLCIAS if the cystic portion cannot be removed. In case, so surgery combined with radiotherapy or surgery coupled with a gamma knife, better outcomes in terms of amount of resection and quality of life have been attained because to technological advancement and the introduction of new equipment such endoscopes and neuronavigation. So the aim of the work is we aim in this paper to study the possibility of achieving a higher rate of resection by using an additional instrument that is endoscope. So the clinical illustration is endocrine dysfunction and visual compromise are the most prevalent presenting symptoms, followed by hydrocephalus related symptom. Growth retardation is a common observation in kids with craniopharyngiomas. So the investigation and diagnosis, MRI, is typically used to diagnose craniopharyngiomas. Since craniopharyngioma frequently have calcified solid and cystic tumor components, a computerized tomography, that is CT, is also performed if an MRI of the head is suggestive of a craniopharyngioma in order to look for calcifications. So for the pre-operative workup, endocrine and ophthalmological exams are required. So the patients and methods in this study, there were total 11 patients who had been pre-operatively determined to have them by radiological studies and confirmed to have them by post-operative histological analysis were included. All of these tumors had solid and cystic components, and comprehensive neurological testing and lab analysis were performed. Prior to and following surgery, MRI, visual, and endocrine tests were performed. After surgery, MRI were done again at 3, 6, and 12 months. Over the course of the follow-up period, which lasted between 6 months and a year, a subfrontal technique was used to remove each tumor. Our method relies on performing a small right frontal lap, a linear dura opening parallel to the base of skull, smooth retraction of the frontal lobe, opening of basal cisterns, and decompressing the brain by puncturing the tumor cyst and gently pulling the bulk of tumor out of the brain. If the tumor is located in a retrochiasmatic region, the lamina terminalis is opened. The decompression is typically carried out utilizing the microsurgical approach up until the point when we determine the further resection is not risk-free. So the rigid endoscopes, 0 degree, 30 degree, and 70 degree are now used during surgery along with endoscopic microforceps, microdissectors, and bipolar coagulation. So all three of different angle endoscopes are utilized to examine the tumor site during surgical removal. The inferior surface of optic nerves and superior posterior limit of tumor attached to the hypothalamus were both examined using 30 and 70 degree scopes. By dissecting and gently pulling on tumor at this 2 level with endoscopic forceps and microdissectors, the majority of tumor is typically removed using the 30 degree endoscope. The 70 degree endoscope provides a strange image for dissection, although it is typically used to confirm the complete resection. So to confirm that entire resection had been accomplished, many endoscopes are used at various angles at the conclusion of the procedure. So the results, 11 patients were included in the study. All of them underwent subfrontal operations with the introduction of an endoscope at the conclusion of the procedure for evaluation of tumor removal and, if possible, dissection of any leftover components. 4 examples of the childhood craniopharyngioma variant were found, while the rest cases were of the adult kind. There were 5 female patients and 6 male patients. In 6 cases, complete removal was accomplished. In 5 adult cases, due to adhesion due to hypothalamus and perforating arteries, subtotal resection was accomplished in 5 individuals, 3 of whom had post-operative irradiation. So 5 patients required the insertion of OMIA reservoir because the cystic portion could not be removed. In 5 cases, a VP shunt was implanted. Only 2 of the patients who acquired diabetic insipidus DI permanently following surgery. Before surgery, there were 2 patients that had pituitary hypofunction. After surgery, there were 3 cases. All patient had impaired visual fields. 2 patient visual fields got better following surgery, while the other 2 got worse. Using this method, no decline in visual acuity was noticed. 2 patients died after surgery, one from uncontrolled hypernatremia and other from complications following an intraoperative bleed. So nearly 14% of CNS tumors are benign growth called craniopharyngiomas, which are found at the base of the skull. The entire resection of craniopharyngioma is a significant challenge for neurosurgeons due to anatomic intricacy of this region and the nearby tissues that may cause endocrine, autonomic, and behavioral issues. The aim of the surgeon must be complete surgical resection of craniopharyngioma because the survival and recurrence rate are correlated with the amount of resection, but this cannot be done at the expense of the patient's quality of life, such as by causing additional hypothalamic manifestations. There are some restrictions that must be taken into account before surgery, such as childhood obesity, which may be a predictor of severe postoperative hypothalamic dysfunction, and older patients with morbidities. There is debate over whether craniopharyngioma excisions should be partial or complete before radiation. So the adherence of the tumor to the hypothalamus is one of the limit to total resection. To prevent serious hypothalamic affection, grabbing attempts to remove a tumor that cannot be sucked should be avoided. The other restriction is tumor addition to arteries and perforators without a cleavage plane between them. The enormous tumor volume is frequently the cause of difficulties, which are typically of a hormonal or visual origin. These complications are due to the intricate anatomical relationships between the tumor, the visual tract, and the hypothalamus. So no appreciable variations in the frequency of hormonal and or visual problems were found between our patient group and control group. After tumor debulking using our method, the visual field was improved in 2 patients while it deteriorated in another 2. All patients experienced diabetes insipidus following surgery. However, only 2 of them developed a persistent condition. After total resection, recurrence is said to occur between 11 and 31% of the time. According to many writers, partial resection carries a higher risk of recurrence, which can range from 22 to 100%. Our mortality rate was 7%, with 2 patients dying as a result of long-term hyponatremia and inadvertent intraoperative bleeding, respectively. So the conclusion, the best surgical method for treating a craniopharyngioma is still total excision, but still in our experience, endoscopy appears to facilitate the safe excision of craniopharyngioma using microsurgery. So you can see the small clip from surgery. This is the small clip which was recorded in surgery. You can see the video. Dissection of Sylvian fissure. Now we are moving to the right labium section. You can see the tumor. Left optic nerve. Left ICA. The tumor, we've already seen the tumor is dissected. can see the endoscopic view. That's it. Thank you. If you have any questions, you can let